Hello, I'm Dr. Vasundhara, Senior Consultant Gynecologist, Laparoscopic and Robotic Surgeon. So we shall go through the first part of the LATE test, and I'll take you through the first question. Which type of pelvis is most associated with the persistent occipito-posterior position? For this question, answer would be C, that is anthropoid pelvis. As you all know, the most common presentation is occipito-anterior, which is most favorable position for the fetus to deliver, and which type of pelvis favors this is a gynecoid pelvis. And as we all know, according to Cardwell-Mollis pelvic classification, we have 4 different classifications. Classifications are gynecoid, platyploid, anthropoid, and android pelvis. The gynecoid pelvis is the most common pelvis what most of the women have, and rest of the pelvises vary, and accordingly the presentation also vary. If you see here, that is this is the gynecoid part, and next is the platyploid, and another is anthropoid, and another is android. As we go to each type of pelvis, the distance between the anterior and posterior part varies. In gynecoid, both anterior and posterior are equal. Platyploid, a kind of equal. In anthropoid, the anterior diameter is more when compared to the posterior. In android, the least favorable position, favorable pelvis, the posterior part is very, very less. So usually we need to have a proper posterior part to accommodate the baby's rotation and for the baby to come out like this. So for which gynecoid or platyploid are the most common favorable pelvises. But if it is posterior presentation, that is persistent posterior presentation, we can expect anthropoid type of pelvis. As I already said, gynecoid is most favorable, platyploid is wide and flat pelvis, anthropoid is long and narrow in pelvic inlet. So the presentation also varies according to this. So second question is, which of the following statements regarding sexual differentiation is correct? Among us the options, the correct answer is C. Mutation in the SRY gene can result in individuals with a 46XY karyotype developing a phenotypically female appearance. The explanation here is individuals who are 46XY who have mutations in SRY gene can develop a female phenotypic female. So this demonstrates the discordance between a female genetic between a genetic and phenotypic sex. Usually, when we take other options, like SRY gene is located on the X chromosome, which is essential for ovarian development, that is wrong because SRY is located in the Y chromosome. And coming to the next option, both male and female embryos have morphologically indistinguishable genitalia under 8 weeks of gestation is incorrect because male and female embryos are morphologically indistinguishable for only 6 weeks of gestation. The differentiation starts after 6 weeks of gestation. By 8 weeks, they are fully differentiable. The third is differentiation of internal and external genitalia into male and female type is independent. Here, this is wrong. This is dependent on the testicular function. So, ultimately, the female phenotype is formed with the absence of male chromosome. So, if the Y chromosome is there, that develops into a male-female phenotype. If Y gene is absent, that develops into a female phenotype. So, the key points here are the genders like XY and gonadal genders and female phenotypic genders. The 3 types of genders we see. For the first 6 weeks, both male and females are indistinguishable. And after 6 weeks, the sexual differentiation is initiated by the Y chromosome, as I already said. The SRY gene is located under the Y chromosome, which decides the development of the testis or the ovary. And additional, sometimes, certain uncertain autosomal genes like SOX9 and some other genes, mutations lead to disrupting sexual differentiations. So SRY gene disorders like 46XX males can occur via translocation of the SRY gene into Y chromosome. 46XY females occurs if SRY has a loss of function of mutation. So basically we have to understand that is the differentiation of the male or female depends on the Y chromosome. As you all know, during development, the embryonic urogenital structures, how they differ, how they develop is the genital ridge develops into ovary in female and testis into male. Primordial germ cells develop into ova and spermatozoa respectively. Sex caudal stem cells develops into granulosal cells and seminiferous tubules and settler cells in male. And these mesonephric tubules, that is Wolffian tubules, develop into epiferon and parapheron in female, and efferent ductules and paradymes in males. And this is the mesonephric ducts which develops as Gartner's duct in female, and the epididymis, vas deferens and ejaculatory ducts in males. This paran is mesonephric ducts. These are the very important ducts which fuse from up to below to form as fallopian tubules. The upper part is unfused, that remain as fallopian tubules. The middle part remains closed, that forms as uterus, and the lower part remains closed but cavitation happens, which ultimately results in uterus, upper vagina. And the lower vagina and other parts are being formed by the urogenital sinus. The urogenital sinus develops as bladder and urethra, and bladder, urethra, and prostatic article in male. And the other lower one third of the vagina as well. The genital tubercles develops into clitoris in female and glans penis in male. Urogenital folds are very, very important in formation of labia minora in female and flora of penile urethra in male. Labioscrotal squelix develop as mesora in female and scrotum in male. So whatever structures are formed either in male and female are formed from the same genital ridges but difference into different organs depending upon the Y chromosome and the hormonal presentations. Third question is, a 26-year-old woman presents with bilateral ovarian enlargement during pregnancy. Ultrasound shows multiple thin wall cysts and she has elevated serum beta HCG and mild maternal virilization. Which of the following is most likely diagnosis? The correct answer here is the thecal luteal cysts. So, because as you all know, this thecal luteal cyst is formed by the excessive luteinization of the theca interna cells under the HCG influence. Usually this presents, many times this is asymptomatic, but sometimes when it is swollen may cause acute abdominal pain either because of the hemorrhage or rupture or twisting. And very rarely it causes maternal virilization because of the underlying hormones that is represented with the balding of the pregnant women and sometimes hirsutism and clitoromegaly. And fetal virilization is very rare because it doesn't cross placenta. The diagnosis is usually with ultrasound. Prognosis is very self-limiting unless it ruptures and causes severe hemorrhage, which has to be addressed surgically. And we are coming to other options that the first option, that is PCOS, that is absolutely wrong because PCOS diagnosis itself in the diagnosis itself says that ovarian cyst should be of less than 10 centimeter, which is not correlating. OHSS, that is ovarian hyperstimulation syndrome, this usually develops with a kind of iatrogenic which is developed after the ovulation with injections like HCG and FSH. And this has other features like SATs and hemoconcentration and all those, but these do not develop into a kind of thecal luteal or carpal luteal cyst. Endometriotic cyst or chocolate cyst is altogether a different condition. Many times they suffer with infertility. Even if they do, the blood with or a thick mucinous cyst will be, a blood cyst will be there. The fourth question is, which of the following statement best explains the increased iodine requirement during normal pregnancy? The correct answer is, iodine requirement increases due to fetal production of thyroid hormone in the blood in second half of the pregnancy. The explanation here is, fetus doesn't develop any thyroid gland till 12 weeks of gestation. The thyroid starts developing after 12 weeks. Till then, the baby is completely dependent on maternal thyroid hormone. So, as in first trimester, thyroid has to be given for the baby's requirement if the mother is hypothyroid. In second trimester, the thyroid starts developing for the baby. Then the iodine requirement, this whatever thyroid hormone the baby is secreting crosses the placenta, and it causes the indirect demand for the maternal iodine. So the other options are there is reduced maternal thyroxine production during pregnancy, which is incorrect. Actually, T4 increases. And the other option is the principal sources of iodine excretion is placenta, which is wrong because excretory source here is kidney, not placenta. Maternal supplements contain excessive iodine are not associated with any fetal thyroid dysfunction. As I said, thyroid do crosses placenta, and fetus for the first 13 12 weeks is completely dependent on mother's thyroid. So that definitely crosses to placenta. So whatever thyroid or maternal iodine supplements what we are giving, those cross through placenta. Which of the following statements regarding corpus luteum after ovulation is correct? The correct answer is, in the absence of pregnancy, the corpus luteum typically undergoes apoptosis 9 to 11 days after ovulation. Yes, because the corpus luteus is called a transient endocrine organ, which is usually, if the pregnancy happens, the corpus luteal further develops. If the pregnancy doesn't happen, the corpus luteal apoptosis happen, and it starts for the next cycle of menstruation. So when we are coming to other options, like the corpus luteal maintenance after ovulation depends on FSH hormone, which is absolutely wrong because FSH is a preliminary, the first half hormone, and LH is the second half of hormone, which is stimulating the corpus luteum. The ovarian progesterone production during the mid luteal phase drops below 10 milligram per day, which is even wrong because ovarian progesterone peaks in corpus luteal, in the second half, which is the indirect test of ovulation, which is usually after ovulation, the progesterone peaks and a rapid fall of progesterone happens, which ultimately results in menstruation. Third option is spiral arteries of the endometrium arises from the straight arteries and do not undergo a coiling during secretory phase. This is even wrong because spiral arteries arises from the radial arteries, undergo rapid lengthening and exhibit greater coiling during secondary phase. So as this endometrium layer thickens, this coiling of the spiral arteries happen, and with the menstruation, when the menstruation begins, this fall of these arteries happen and fresh regain of the vascularity happens. Which of the following statement correctly describes the key features of circumvallate placenta? The answer here is C. The option C. The chorionic plate is smaller than the basal plate, and the periphery is surrounded by the thickened a gray-white circular ridge formed by the double fold of chorion and amnion. Yes, this is correct because the circumvallate placenta is a thing wherein the peripheral part is thickened, opened, gray-white ridge caused by the double fold of chorion and amnion, which in which the chorionic plate, which is called the chorionic side of the plate is much smaller than the basal plate. Explanation of other options are option A, that is chorionic plate extends fully to the periphery of the placental disc, is wrong because in extrachorial placentation, the chorionic plate usually doesn't extend fully to the periphery. It is much smaller than the basal plate. The option B, placenta periphery is covered by the single layer of amniochorion. No, this refers to the circumvallate placenta, which I have mentioned, in which that is a double fold. That the option D, there is a deposition of fibrin and whole hemorrhage between the placental disc and single layer of amniochorion. This describes features of circumarginata. This is the feature of circumarginata, not circumvallata placenta. Which of the following best describes the unique aspect of fetal circulation compared to adult circulation? The correct option is well oxygenated blood from placenta preferentially supplies the fetal heart and brain due to parallel ventricular function. Yes, this is true because switching over of the placental circulation happens at the time of birth. Till then, placenta is the major source of oxygenation, and not the lungs. The same is explained here. The fetal circulation allow well oxygenated blood supply from placenta to bypass the liver and lungs, preferably supply the brain and heart due to parallel ventricular functioning with a specialized anatomical shunting, that is foramen ovale and ductus arteriosus. And when we are coming to option A, the left and right ventricles work in series. This is wrong because they do not work in series. They work in parallel. Most of the right ventricular output passes through the fetal pulmonary vasculature for oxygenation. This is even wrong because the placenta is the major source for oxygenation, not the lungs. The oxygen content of the blood entering the fetal heart from the inferior vena cava is higher than that of blood leaving through placenta. No, placenta has the highest concentration of oxygen, not the inferior vena cava. Question number 8. Which of the following statement regarding the use of selective SSRIs, that means selective serotonin receptor uptake inhibitors, in pregnancy is correct? Correct answer is B. Paroxetine is associated with increased risk of cardiac anomalies and should be avoided in women planning for pregnancy. SSRIs are the drugs which can be safely given during pregnancy, but certain drugs are to be avoided, and that is one, that is paroxetine. Paroxetine is as I already said, that is an exception of SSRI because it has the risk of cardiac anomalies. Explanation to other options are: option A, all SSRIs are considered as major teratogenics, that is absolutely true. SSRIs are all safe except paroxetine. Neonatal behavioral syndrome associated with maternal SSRI usually typically requires prolonged hospitalization and intensive care. This is even wrong because major of the SSRIs are very good. And even if the depression happens, that is short lasting, lasts for only 1 or 2 days, and that too self limiting. There is no association between SSRIs and persistent hypertension of the newborn. This is incorrect because SSRIs do cause a certain kind of depression, but not major and not very dangerous, but has a kind of risk which has to be addressed. Question number 9. Which of the following statements regarding HCG in early pregnancy is correct? The correct answer is B. Maternal serum or urine HCG can usually be detected as early as 8 to 9 days after pregnancy. Yes, HCG, that is true. And HCG is the thing which is secreted with the syncytial trophoblast. And that you remember 8 for HCG because HCG is the thing which can be observed from day 8 of in the maternal urine, and the peak level happens at from 8 days, and the depletion starts from 8 multiplication 16, that from the 16 weeks, that is 8th day, 8th week, and 18 to 16. So when we come to other options, that first option, HCG is produced with the corpus luteum and prevents inovulation. This is wrong because HCG is secreted with the trophoblastic cells, that to syncytial trophoblasts. Serum HCG levels plateau by 8 weeks of gestation, and this is wrong because this peak happens at 18 weeks and plateau begins from 16 weeks. As I said, multiplication of 8. The main structure of HCG is homodimer identical to that of SH and TSH. This is wrong. HCG is heterodimer. The alpha part is similar to TSH and FSH, all those, but beta is exclusive to pregnancy. Which of the following is most common chromosomal abnormality associated with first trimester spontaneous abortions? As we all know, the correct answer is trisomy. As we all know, most common causes of abortion in first trimester are chromosomal anomalies, and among those, trisomy is most common, and that carries 60%. And for other options, explanations, option A, the balanced structural chromosomal rearrangement is incorrect. This is wrong because this rearrangement can cause pregnancy loss, and they are much less frequent, and they are not very much associated with pregnancy losses. This Turner's is monosomy is also incorrect, because the syndrome itself is a very rare entity, and this is most single specific chromosomal abnormality and not most common, that too. And this is a kind of life viable condition. Abortions do not happen frequently. Triploidy is also observed very less when compared to the trisomy. Question number 11. Which of the following is a notable teratogenic effect of methotrexate exposure during pregnancy? The correct option is craniofacial and skeletal abnormalities with fetal growth restriction. As you all know, methotrexate is the most common drug which is used for SLE conditions. Unfortunately, if any pregnant woman has exposed to this drug, careful evaluation should be done, because methotrexate embryopathy is particularly notable with, as I said, craniofacial and skeletal abnormalities. Explanation to other options. Option A, neural tube defects and polyhydramnios, is incorrect, because polyhydramnios is not noted with methotrexate. Cardiac malformations and macrosomia is also not noted in methotrexate embryopathy. Renal dysplasia and limb overgrowth, that is a kind of defect which is not at all related to methotrexate embryopathy. As you all know, methotrexate is a folate interacting drug. So this, whenever we give methotrexate, we have to carefully assess the mother condition for methotrexate toxicity and whether that can be given or not. And teratogenicity has also should also be considered. It is a potential teratogenic, and as I said, this has embryopathy classically manifested. Breastfeeding, yes, methotrexate crosses the breast milk, so breastfeeding women should be given a care. And this has a protocol. There is a standard protocol of giving methotrexate for, usually in women, we usually give for ectopic pregnancy in gynecological view. In for other conditions, in so many conditions that is being used, like gestational trophoblastic diseases and SLEs and all those. So the weight is calculated according to 150 mg per meter square, that is the body surface area for a single dose, and for multi dose protocol, that is 1 mg per kg, not meter square. Leucovorin is not needed for single dose but is for multi dose. Beta HCG to be monitored from day 4 and day 7. There may be a slight increase of day 4, so the day 7 value is more important. Indicators for additional dose depends on the beta HCG only, and the surveillance should be with the beta HCG tapering thing. When we are giving methotrexate, we have to screen the patient for toxicity and tubal rupture, whether the pregnancy is, we have to rule out properly for the ectopic pregnancy, breastfeeding, immunosuppression, and hepatic condition, other whether that patient, other hepatic and renal conditions should also be ruled out. Methotrexate, as I already said, should be given intramuscularly, calculated on body surface area, and drug reaction should be observed for certain time, and when, if toxicity is noted, to be added with the leucovorin. Question number 12. According to the current ultrasound guidance, which finding is diagnostic of placenta previa? Placenta previa is a dreadful placental condition. The correct option is placenta overlies the internal cervical os to any degree or reaches its margin at or after 16 weeks of gestation. Yes, because placenta previa is a condition that is diagnosed radiologically, and it has certain features where we can classify that particular lady into placenta previa, because the time of assessment is very important. That can be labeled placenta previa only after 16 weeks of gestation. Placenta previa is different from low-lying placenta. Low-lying placenta is in which the margin should be 2 cm away from the os. Previa is a condition wherein the placenta either touches the os or completely covers the os. Ultrasound is the major diagnostics tool. Imaging The transvaginal probe gives us a better idea, and that helps us in all ways in identifying, not only identifying the placenta previa, in management too, because we can identify the bladder invasion and other structures and how severe is the placenta. And as you all know, other types of placentations like marginal cord insertions, that is bladder lower placenta, wherein if the placenta is like this, cord insert like this. Usually placenta cord will be in the center of the placenta, or proper normal. Marginal is like this. Elementous is the condition wherein there will be a gap between a cord and placenta, where, but the thing is, these are supported with the transversing membrane. And another placenta previa is another condition, only vessels will be traversing without being any supports, at least with even with a membrane. So explanation of other options, that is option A, the inferior placental edge lies within 2 centimeter, that is lower lying placenta. Placenta is within 3 to 4 centimeter of os before 16 weeks, that is wrong because that has to be after 16 weeks. Placenta overlays the internal os but resolves by 32 weeks, even that is wrong. Many a times placenta, it resolving is not considered at placenta. Resolving is the not the diagnostic feature of placenta previa. Question number 30, which of the following statement regarding gastroschisis is correct? The correct answer is gastroschisis is more common feature of younger mothers and has a high survival rate. Explanation is, this is by definition, gastroschisis is a full abdominal thick defect wherein abdomen is not completely seen, through which all the internal contents are openly seen. The pathology is, it results in bowel and other internal structures coming out, and there will be no covering onto that. And this is the obvious diagnosis naked, and ultrasound can definitely diagnose. It is very rare, incidence is 1 in 200,000 births. The most common is the younger women are more prone for this condition. Coexistent bowel anomalies maybe 15%. Fetal growth restrictions is expected 15 to 40% of the cases. Usually not associated with any genetic abnormalities or chromosomal anomalies. Prognosis is very good with the surgery. Omphalosil is a condition, a similar condition like gastroschisis. The prevalence is very, very less compared to gastroschisis, and this has association with other chromosomal abnormalities. The major difference between these two is this has a covering of a gestational sac, whereas the gastroschisis doesn't have any cover. The bowel herniates through naked defect. Survival rate definitely depends on the isolated. If it is isolated, 90% of the survival rate will be there. Drops to 80% when other structural abnormalities are seen. When coming to other options, option A, gastroschisis is associated with chromosomal aneuploidy. As I said, this is not common. Abdominal wall typically is left to the umbilical cord incision. No, that is wrong, because that is right to the defect is typically right to the umbilical cord incision. Bowel herniates into the amniotic cavity. This is wrong because this is the feature of omphalosil. Question number 14. Which of the following is true regarding cell-free DNA screening aneuploidy in pregnancy? The correct answer is cell-free DNA screening has pooled sensitivity 99.7% for trisomy 21 and with a specificity of 99.9% for autosomal trisomies. Yes, first option is, it is most commonly performed prior to 6 weeks of gestation. No, it is usually performed from 9 weeks of gestation. Option C is also wrong because false positive rate for detecting exceeds 5%. That is absolutely true because that is very, very, very less. That is less than 0.2%. American College ACG strongly screening for all microdeletion syndrome. That is even wrong because ACOG is not recommending cell-free DNA as a routine, and because validation should be there. As I know, cell-free DNA, as I said, this is the maternal blood test. These are the cells which are released from the apoptosis of the this placenta, which are released into the maternal circulation. This is usually, used to diagnose the chromosomal anomalies, mainly trisomy 21 and trisomy 13 and 18. And it has got very, very good sensitivity, that is 99.7 sensitivity. And for trisomy 21. For 18, it is 98% sensitivity. For trisomy 13, it is 9. Overall, the efficacy, the sensitivity is near 99%. False positive rate is very important, that is less than 0.2%. The interpretation and counseling is very much needed, and the patient should be clearly counseled that though this has got 99% sensitivity, and there is still a chance of 0.2% failure. If we still have doubt on the cell-free DNA, we can we can give them the option of amniocentesis or choriocentesis if that lady falls into that case. Question number 15, that is during administration of Pudendal nerve block for vaginal delivery analgesia, the most accurate needle placement is. The correct answer is against the vaginal mucosa just beneath the tip of ischial spine. Yes, because the Pudendal nerve block is given at the Pudendal nerve where it crosses beneath the sacrospinous ligament, wherein we take ideally speaking, the indications for this is any intervention which we do onto the vagina, like vaginal delivery, vaginal repair, episiotomy, tears, and all those. So why do we take Pudendal now means because it is the area, it gives the sensory innervation of the perineum, clyde, external genitalia, the ventral branches of S2 to S4. The anatomical landmark is to identify identify the lateral margin of the lateral part of the vagina, this identify the sacral promontory and identify the sacrospinous ligament. At the point of ischial spine, insert your needle and just give, before giving the block, withdraw, make sure no blood is drawn, and elevate 1 to 2 centimeter margin of the vagina and give the injection. The sensory areas, the nerve roots take up this injection, and analgesia will be given. The major danger is injury to the vascular bundle. It effect starts from 3 to 4 minutes and usually lasts for the time where the moderate kind of episiotomy can be done. If it is taking prolonged time, you have to take either you can give another dose, or you can go for the local injection to the episiotomy tear. So this is the total dose should not exceed 300 mg, and the dose calculation can be of same, on an average for 50 women. The complications, as I said, intravascular injection should be avoided. Hematoma formation is another thing. Instance of very rare instance of pudendal neuralgia has been reported. Infection is also very rare feature. When we come to other options, option A, along with the vaginal wall at the level of pubic symphysis, that is absolutely wrong, because pubic pudendal nerve lies at the sacral promontory into the perineal body at the level of ischial tuberosity. No, ischial tuberosity has the pudendal nerve, the perineal body lies down, and through the rectal mucosa in the midline behind the sacrum. That is even wrong, because the sacrum, the most prominent area is the ischial spine. Question number 16. The vacuum assisted delivery, the optimal placement of vacuum cup is. The correct answer is at the flexion point, which is 3 cm from the posterior fontanella and 6 cm from the anterior fontanella in the sagittal suture. So flexion point is the optimal site wherein we apply the vacuum, which is usually, if the head like this, lies like this. Anterior fontanella will be here, and imagine this is the pelvis. And anterior fontanella will be here, and the posterior fontanella will be here, and we'll be applying the vacuum like this. So we'll be more near to the posterior fontanella rather than the anterior one, which is 6 cm and 3 cm away like this. And importance of this site is it gives us a major suction point. It helps in traction, good traction. It maximizes the traction and minimizes the cup detachment, and it flexes the fetal neck properly and delivers the smallest diameter of the head through the pelvic outlet. So if we, the advantages is, whenever we are placing this suction cup, we have to make sure no other structure is in between the scalp and the vacuum, and adequate vacuum is created, and a suction force traction is being maintained, and a proper traction is given. Usually the cup's diameter is 5 to 6 centimeters, and we know the flexion point where this has to be applied, and the proper diagnosis, proper traction can be given. And we coming to the other options. The first option is over the posterior fontanelle. That is wrong. That should be 3 centimeter. And at 3 centimeter anterior to the anterior fontanelle, that is even wrong. 6 centimeter. C is correct. At the coronal suture, that is wrong because that has to be in the sagittal suture. Question number 17. Immediately after delivery, a term newborn is apneic with a heart rate of 80 bpm. According to the standard neonatal resuscitation protocol, which of the following is next appropriate step? Next step is provide positive pressure ventilation while monitoring SpO2. The correct option is A. In neonatal resuscitation, there is a protocol. So, after initial assessment, if color, tone, the Apgar score is good, the baby is vigorous for 10 to 30 seconds, baby should be handed over to mother with routine care. If heart rate is less than 100 bpm, if any apnea is seen, initiate the positive pressure ventilation. And if the heart rate remains less than 100 bpm, check the chest movements and then consider intubation. If the heart rate is less than 60 bpm, after adequate ventilation, then begin the chest compressions and make sure the PPV is 100%. And if the heart rate is still less than 60, then IV epinephrine should be considered. And if it is labored breathing and cyanosis is seen, airway should be cleared, monitor SpO2, and CPAP has to be considered. And all equipment should be clearly seen. And when we are coming to other options, chest compressions, that is, are indicated only, if the BP, if heart rate is less than 60. So this is wrong. Intubation with IV epinephrine is also wrong because that should be considered in persistent bradycardia. Routine care with the mother, that is wrong because baby should be all okay to be given to mother. Question number 80. In the management of obstetric hemorrhage, transfusion of which product is most appropriate when the goal is specifically to increase the critical low fibrinogen level? The option is cryoprecipitate. Yes. So we shouldn't be going with the whole blood option A because many times, ideally speaking, if it is hemorrhage, obstetric hemorrhage, whole blood is the first option. But here he is specifically asking to correct the low fibrinogen, that has cryoprecipitate. Cryoprecipitate is a byproduct which has got rich fibrinogen, which helps in correcting the fibrinogen levels. Whereas, as you all know, there are different types of blood products. The whole blood, wherein it has got hematocrit of 40%, contains the RBC, plasma, fibrinogen with less platelets. The packed red blood cells, packed PRBC, that is called PRBC, contains RBC with minimal fibrinogens and no platelets. FFP is very, very rich in fibrinogen with no platelets. Contains good amount of colloid. Cryoprecipitate contains good fibrinogen and other clotting factors, no platelets. Platelets are exclusively for platelet disorders. Question number 19. According to the current definition, which of the following best describes the post-term pregnancy? Post-term pregnancy is, the option B is correct, that is 42 completed weeks or 294 days completed from the last menstrual period. We should know that, as we all know, 40 is the term, from 40 to 42 is late term, beyond 42 is post-term. So this has to be the correct option. So option A, pregnancy that has reached 41 is wrong, 42 should be there. Option C, pregnancy with a fetus showing features of post maturity at any gestational age. This is altogether clinical diagnosis, not the gestational age thing. Pregnancy confirmed as postpartum solely by the dates of last menstrual period without ultrasound correlation. No, this shouldn't be correct because there is a standard criteria which is corresponding with the last menstrual period and crossing 42 weeks of gestation and with the last menstrual period. Post maturity syndrome is a entity wherein baby shows certain features like wrinkling, alert, a kind of vigorous and peeling of skin. All those will be seen with clinical features like oligohydramnios. And these infants are more a kind of mature, usually alert, unusually alert, and they appear old and they are a kind, sometimes they may show a kind of growth restriction. Incidence is a bit less, almost 10 to 20%. Algohydromias will obviously seen because the age advances that amniotic fluid comes down. Question number 20. Which of the following statement is true regarding monozygotic and dizygotic twinning? So the correct option is monozygotic twinning instance is increased with assisted reproductive technology. This is a very good, important point because with the infertility rate instance increasing, the ARTs are increasing, the twinning rate is also increasing. As I already said, ARTs are the most, ARTs are the common for twinnings because they try to put more embryos for their success rate. So as number of embryos are put, number of fetuses formation is also the likely. So multifetal gestation is most common with ARTs. So among this most ARTs depends like this zygosity like monozygotic, dizygotic, and all these depend on the number of embryos or type of eggs based on the type of eggs and how and when the embryos are divided. The dizygotic twin is a condition wherein it results from the fertilization of two separate eggs with the two separate sperms. So they are almost like two siblings. And in monozygotic, identical twins, and in which this entire twinning process happens from a single embryo. So this even has a kind of differentiation. It is DD, MODI, and MOMO. That means dizygotic, diamniotic, and if the twinning, the division happens less than 72 hours, that is dichorionic diamniotic. And if it is between 4 to 8 days, and monochorionic and diamniotic. If it is after 8 days, monochorionic and monoamniotic. If it is beyond, chances of conjoined twins are very high. The monozygotic twins can have discordant growth because of the placental circulation defects. The other options, like option A, dizygotic twins are also known as identical twins, absolutely wrong because dizygotic are like two siblings. They are two different eggs, two different sperms. They're absolutely two different siblings growing at the same time. Monozygotic twins always have identical phenotype. That is wrong. Though they have a genetic identity, facial features may slightly vary. Twins of opposite sex are almost always monozygotic. That is even rare. Question number 21. In the event of maternal cardiac arrest during pregnancy, what is the recommended time frame for initiation of perimortem cesarean delivery to optimize both maternal resuscitation and fetal outcome? Perimortem cesarean delivery is an important condition wherein we have to act immediately to retrieve the baby. So that should be the correct explanation is within 4 to 5 minutes. Within 4 to 5 minutes, till 3 to 4 minutes, up to 4 minutes, mother still can hold the placental blood supply to the fetus, but beyond that, chances of survival comes down. The correct option. The maternal explanation is The American Heart Association and the other guidelines, what they say is, if the baby is delivered within 5 minutes, 98% of chances of live baby are there, and as the time advances, the chances of survival comes down. And question number 22, according to the National Heart, Lung and Blood Institute, which combination of finding fulfills the diagnosis of metabolic syndrome? The correct answer is elevated triglycerides, elevated blood pressure, and elevated fasting sugars. Yes, metabolic syndrome is a multi-organ affected disease, which with the definition, a cluster of metabolic abnormalities with increased risk of type 2 diabetes and cardiovascular diseases, also called syndrome X or insulin resistance syndrome, in which the diagnosis includes so many criteria, and it has strong association with diabetes, hypertension, atherosclerosis, PCOD, and non-alcoholic liver diseases. Complication, as I said, the condition which are all the most commonly linked, leads to particular systemic effects. The management definitely lies in lifestyle modifications, pharmacotherapy for respective diseases like hyperlipidemia, hypertension, diabetes management, lifestyle management, PCOD management, and all should target to maintain and maintain proper lifestyle with the proper medication affecting the systemic conditions. Question number 23, 26-year primary 18 week gestation, midstream void culture urine showing 10 to the power of 5 units of E. coli. It has no symptoms. Which of the following is correct? Explanation B is correct. This is asymptomatic bacteria and requires antibiotic. Yes, asymptomatic bacteriuria is a significant condition in pregnant women which has to be treated with the antibiotic if we find a significant culture. ASB is by definition is more or less 10.5 culture units, bacterian culture without symptoms, and this is most common organism E. coli. Prevalence is 2%. If untreated, chances of pyelonephritis, increased chance of preterm labor, maternal and neonatal sepsis, and low birth weights are common. The risk factors are urinary stasis. Yes, definitely, standing urine causes infection with underlying diabetes and vesicular-ureteric reflexes. This has to be managed with antibiotics like nitrofurantoin and safe antibiotics. But the thing is, nitrofurantoin should be avoided at times because this crosses placenta, and baby cannot tolerate that nitrofurantoin overload. Other options like option CA, no treatment is required since it is asymptomatic. No, as I said, if culture is showing positive, irrespective of the symptoms, that has to be treated to prevent complications. It is physiological due to urinary stasis, resolves spontaneously. Yes, urinary stasis could be one of the factors, but resolving spontaneously is not wrong. That has to be treated. Repeating culture is needed, but not that is sufficient. Question number 25. 24-year-old pregnant, 28 weeks of gestation, abdominal pain, tenderness. Which of the following is regarding appendicitis is true? The correct answer is ultrasound with graded compression is the first line of imaging of appendicitis. Appendicitis is a tricky situation in treating and diagnosis in pregnancy because though ultrasound, as I already said, pregnancy is a condition wherein it has its own physiological changes, maternal, physical changes. This both affects in diagnosis and management of the appendicitis. The first line, diagnostic tool should be ultrasound or MRI because CT is contraindicated because of the radiation. Incidence is 7 to 80%, but the cross factors like nausea, vomiting, leukocytosis, which are the diagnostic features of appendicitis, are also there in pregnancy because of the physiological changes. That causes a kind of diagnosis discrepancy. And imaging, as I said, ultrasound is the best one. Appendicitis rupture is the most common thing, which puts us into pressure, which can happen 20% in mostly in third trimester of pregnancy. Other options like option B, appendicitis remains in right lower quadrant throughout the pregnancy. It is true that it gets displaced with the position changes with uterus, but it takes its own comfortable place, not always to be. Leukocytosis is always of appendicitis. That is wrong because leukocytosis is a physiological factor, physiological changes in pregnancy too. Appendiceal perforation is rare in pregnancy, that is very common in pregnancy. That can happen in 20% in third trimester. Question number 25, the last question. Following statement regarding cytomegalovirus infection is true. The correct option is vertical transmission risk increases with advancing gestation. Yes, vertical transmission rate increases as the age advances, gestational age advances, which is 36% in first trimester, 40% in second trimester, 72% in second trimester. But the thing is, though the incidence increases with the age, but the outcome, that means the danger decreases with the age. If it is affected with first trimester, the incidence of congenital anomalies are more. If it is in second trimester, a bit less, and much less in third trimester. That is the most advantage. And the most common perinatal infection worldwide is cytomegalovirus. Unfortunately, the transmission is through saliva, semen, and urine, blood, and this thing. But transplacental infection is also recommended. That is the most problematic and concerning factor. And most important thing is maternal IgG antibodies do not prevent recurrence and reactivation. Thinking that patient is diagnosed with IgG indicates that the patient is immune to the condition shouldn't be considered. Though the patient is IgG positive, that indicates that she has been infected with the virus in the past, but there is a chance of recurrence too. That is the most pathetic part of this IgG. Coming to other options, amniocentesis is the most source of heterogenetic. No, this is wrong because amniocentesis is used to diagnose, but that doesn't cause CMV. That is not the major source. And option B, anti-CMV IgG antibodies completely prevent maternal reinfection. No, that gives partial protection, but that is not 100% protection. Option D, most primary maternal CMV infection are symptomatic and easily diagnosed. That is wrong because most of the time this is asymptomatic and mildly diagnosed. That is, the fetus when infected comes out to be a major risk factor. Thank you.